your screen. I'll just let you get started.
Great. Thanks very much, James, and good morning, everyone. Can everyone see this one, my screen?
Yeah, that looks good.
Perfect, thanks. Is there a box on the side, which I think might be the conference? Oh, let me know if I need to shift that.
No, I think we're okay. We see the whole, whole slide.
So first, I just wanted to apologise for not participating in the whole workshop. As James said, it's morning for me, so I've missed most of the presentations overnight, but I'm looking forward to the discussion afterwards as well. So as I'm talking about COVID-19 situational assessment in Australia, and my talk is incorporating vaccine and exposure-acquired immunity into COVID-19 situational assessment. I'll mostly be talking about incorporating vaccine-acquired immunity, and I'll touch on exposure-acquired immunity towards the end. That's still something that is a challenge for us and what we're working through. And this work is a collaboration over the past 18 months with a number of individuals, and a lot of the work's been, that I'll be talking about today, has been led by Professor Nick Golding at Curtin University and the Telethon Kids Institute in Western Australia, but also big contributions from David Price, Jerry Ryan, Jodie McVernon, and James McCaw, who has been leading the National COVID-19 Situational Assessment Team for the Australian government. Oops. There we go. Okay, so first I just thought I'd define sort of what I mean by situational assessment or awareness, and that is knowing the current and likely future status of the epidemic. And the way that we can do this is through a number of quantitative analysis, including estimating the effective reproduction number. In Australia, we've been estimating this metric we call transmission potential, which I'll come back to shortly. Forecasts of daily case incidence and clinical burden, trends in population behaviour, and scenario analyses. So these are these types of analyses have been done by modelling groups around the world to support government decision making, and yeah, we've been no exception in Australia, except potentially this metric, which I'll come back to. So just a bit of context for where who these decision makers are and where our analyses have been going. So we've been reporting weekly, at least weekly, often every couple of days, depending on the status of the epidemic, since April 2020. So we have a national cabinet which was formed in March 2020 in response to the pandemic to improve communication and have coordinated decision making across our 8 states and territories. There's sort of 9 governments to work with in Australia in terms of achieving coordinated decision making, and so we have national cabinet sits the Prime Minister as the chair and the 8 state premiers and members of that committee, and then we have the Australian Health Protection Principal Committee, which is the peak advisory committee to national cabinet, and our Chief Medical Officer chairs that committee, and 8 state chief health officers are members, and it also includes 2 expert members, include modellers Jodie McVernon and James McCaw. And there's a scientific subcommittee to the AHPPC, which is the Communicable Diseases Network of Australia. So we report to both the CDNA and AHPPC every week, and James McCaw provides a verbal update to the AHPPC. And these committees meet very frequently. National Cabinet will meet usually fortnightly. AHPPC meets, has met almost every day since the start of the pandemic, including public holidays and Christmas Day and things like that. So coming back to the analyses that we have been putting forward to those committees, today I'm going to be focusing on this transmission potential, which is something that we've which has been a key metric informing our decision making over the past 18 months because of our context. We've in having sort of sustained periods of 0 case incidents. And so in February 2020, Australia banned all international travel to Australia, with returning residents having to quarantine on their return for 14 days. And that was in state managed quarantine in hotels. And so this graph is just showing how international arrivals plummeted after the introduction of that travel ban. Actually, we stopped all travel from mainland China in early February 2020, and this is showing on the 20th of March when we stopped travel from all overseas travel. And we've actually only just started opening up overseas travel again in the last actually this week, so it's been a long time, and this impacted our epidemiology in a big way. So this is a plot of the case incidence in Victoria, which is where Melbourne is, through 2020. The local cases are coloured in orange with the imported cases in blue. So in March 2020, you can see that there was a small epidemic wave, which was driven by imported cases. And that's when the borders didn't close until towards the end of that month. And so that epidemic was largely imported cases with some local cases. And most of those local cases were actually close contacts of imported cases. And so it was sort of arguably community transmission was never really established during that initial wave of importations. And then we drove case counts to very low levels. And this pattern is a similar pattern around the rest of the country as well. And so driving down to 0 cases in around April, May 2020. In this particular state, so I've chosen to show you the case incidence from Victoria because this is one state that did have a second epidemic wave in 2020 after a quarantine breach towards the end of May, which led to this second epidemic wave, which was mostly or overwhelmingly locally acquired cases, although still a reasonably small epidemic compared to what's been seen around the rest of the world. And again, case counts were driven to very low levels, returning to 0 case incidents by late November. So so then when we were doing situational assessment, we had a number of challenges in relation to our epidemiology. The first, which I won't talk about, was estimating things like the effective reproduction number with a large portion of our cases being imported. But the other challenge was we started using the EpiNow package kindly provided by LSHTM in March 2020. Of course, this was working well for us while there were cases. And when we, towards late April, so this is the estimate of the time series estimate of the effective reproduction number for Victoria through March and April 2020, we can see that towards the end of April, when there was when we had no cases, the model estimate returns to the prior. And that makes sense because there's no data to inform that model. But for us, we had actually I haven't got the lines on there, but we locked down in mid-March, and so we had stay-at-home restrictions. There was only 4 reasons to leave the home, and there was still a small number of cases around in Victoria, and we were easing restrictions, and there was concern for that we could have a breach from quarantine. So the virus was still a threat. It was still circulating around the world, and we were concerned about what was the potential for the virus to spread in our population, but we couldn't measure it because it wasn't there. So this was work led by Nick Golding, who came up with a method for monitoring COVID-19 transmissibility, which was useful in the absence of cases, could tell us something about how people were behaving and the likelihood that the virus, or the likely rate of spread of the virus if it were present, but could also recover the effective reproduction number as it's traditionally measured when there were cases. So this model draws on time series of behavioural data and cases when the virus is circulating. And so these are shown here with the circles. We can see that we distinguish between 2 types of behaviour. Macro distancing behaviour, which was the behaviour which reduces the rate of non-household contact, and micro distancing behaviour, which is the behaviour that reduces the probability of transmission when we do contact others. And so we're measuring these 2 types of behaviour through weekly behavioural surveys run by the national government. And we also, for macro distancing, this is informed by population mobility data, which is made available by technology companies at a daily resolution. And we also had the case isolation effect, which was informed by our case data, which was a time from detection to isolation, which also helped us to understand how quickly our public health system was responding to when there were cases, which we would expect to still be in place, which we would expect to continue, and therefore was helping to tell us about risk in the absence of cases. And so we combine all of this information to estimate this metric that we called the population-wide transmission potential. And so this is an estimate of the ability of the virus, if it was present, to spread in the general population. And then, as I said before, when there are cases, this approach recovers the effective reproduction number. But then during periods of epidemic activity, we can measure the deviation between the effective reproduction number and the transmission potential, which is this one shown here in pink, which has provided us with additional epidemiological insight, which I'll get to in a second. So this is an example of time series estimates of each of those components of this metric that we call transmission potential, or TP. And this is for Victoria through 2020. And you can see, so in each of these plots, the vertical lines are showing the dates of implementation of restrictions, the solid ones, and the easing of restrictions is the dashed vertical lines. So you can see with the mobility how people's mobility increases and decreases in response to the changing restrictions. And the macro distancing behaviour, so this is the self-reported rate of daily non-household contacts, and we can see that decreases when restrictions are imposed. So this is this coincides with the second epidemic wave in Victoria, where we had quite strict stay-at-home restrictions implemented on this date here. So that's in early July, and that was held all the way through to September, October. and then easing through Christmas. And macro distancing behaviour. So this one, we expect this is slightly different. So this is flipped. You expect it to be, this is the people adhering to the, reporting to adhere to the 1.5 metre rule when they're meeting people in public. And you can see that that increases with restrictions being imposed, and possibly due to people's perception of risk as well, that we see this one increase and decrease over time. And the time to case detection, which I mentioned before. So that was, that's these model components. And now I'm just going to show some time series plots of the estimated population-wide transmission potential, the ref, and the deviation between those two over time for Victoria as well. So this is the top panel here is showing you the local case counts and the effective reproduction number measured over that period. And here's our transmission potential. And you can see that there's the pink here, which is showing you the deviation. You can see that there is a difference between the measured effective reproduction number and the transmission potential. So the anticipated rate of spread in the general population is different from the rate of spread among the active cases. And this was consistent with our epidemiological knowledge of the outbreak, because most of the cases during this epidemic was driven by transmission in high-risk settings, so mostly in aged care and other healthcare settings. And that's sort of this positive deviation between ref and TP was representing the fact that transmission was in groups of individuals with higher rates of contact or higher rates of contact than expected from the general population. And so we saw this strong deviation between ref and TP above zero for the entire outbreak, essentially, until it was brought under control. And so these metrics, so both the effective reproduction number and the TP have been are reported in a what we call the common operating picture, which is a publicly available report. It goes to National Cabinet and then is released every Friday publicly on the government website. And so there we go. That one's supposed to be around ref, but it's around day since the last community case was notified. But if you look at this row, the row just below, you can see that we report the effective reproduction number for each of Australia's 8 states and territories. And we only report this when there's more than 20 cases in a state or territory. And then the transmission potential is also reported here down the bottom. And what we can do, what we've been able to do with the transmission potential is is also separately estimate the relative transmissibility of different variants, so that we can provide an estimate of how fast we expect a variant to spread if it was present in the population. So you can see down the bottom there that we've had, so this is from July 2021, and we had both a transmission potential reported for the Alpha variant and the Delta variant. So that's a lot of background into this metric that we've been relying on as an understanding of risk of spread in our population for most of 2020 and early 2021, and we're still using now as well. And this has been, and then in probably March, April 2021, we started thinking about incorporating vaccination into that metric, so that we could continue to have an understanding of the potential for spread in the sort of post-vaccination era. So we So to do that, we use an age-structured next generation matrix model and our coverage data by age, product, dose, and location. That's just like by location, I mean just state or territory, and estimates of vaccine effectiveness against both acquisition of infection and onward transmission given infection in vaccine recipients. And so the plot on the right is showing estimated change in transmission potential due to vaccination over time. You can see here that we rolled out the vaccine a bit slower than many other countries around the world. The start date for our vaccine rollout was I think it was the 20th of February, and the rollout pace was quite slow up and although this is sort of the effects are kind of dramatically decreasing towards the end of the plots there. So this was last week, and so in one of the high states too, we're estimating a 55% reduction in transmission potential, and then the state that's rolled out the least is in Western Australia, where it's 37% reduction. And this is how, so this is a plot of transmission potential. So the estimated transmission potential if only vaccination had changed. So that's incorporating those effects that I just showed in the previous slide. This is assuming that there's no changes in distancing behaviour or time from symptom onset to isolation. So only the vaccination has changed estimates. And here we're accounting for transmissibility of wild type Alpha and Delta variants. This first segment is wild type. Then the red dashed line is showing an increase in transmission potential due to Alpha variant, and then the second red line is showing an increase in transmission potential due to Delta. The vaccine rollout start date is shown in the blue line, so we can see that it sort of starts to creep down, and then we imposed said that Delta is now the dominant risk, and kind of went backwards, but then we've had a significant decrease in transmission potential due to vaccination over the past couple of months. And then this is, I'm just showing how we've been reporting both transmission potential with and without vaccination to our decision makers on a weekly basis. So this is so these plots here in the middle, so this is the transmission potential with vaccination is shown is the green line. Transmission potential without vaccination, so that's just varying in response to changes, mostly varying in response to changes in people's behaviour, so macro and micro distancing behaviour. So that's shown in the grey. And I've put the case counts since the 1st of June for both New South Wales and Victoria as well. So you see, so in New South Wales, it's currently a declining epidemic, and there's easing social restrictions and high vaccination coverage, so 88% two-dose coverage in the 16 plus. And we have a national plan where the goal is to maintain transmission potential around 1. And so we've had, so you can see in Sydney here, they've been maintaining transmission potential around 1, which has been maintained there due to the continued vaccine rollout, despite the easing of restrictions. So you can see the divergence between these two curves. And Victoria is in a similar position, although where sort of the epidemic appears to be around the peak and is or stable and potentially declining. And we've so Victoria's just coming out of a lockdown as well, but not as quickly. And so those restrictions, so the levels of population mobility and macro and micro distance payment is increasing, but still reasonably steady. And there's still a little bit behind Sydney in terms of vaccination coverage. but again, transmission potentials just crossed below 1 in the last couple of weeks, and yes, so we're hoping to see that epidemic, provided that we don't see dramatic changes in people's behaviours, which might happen. We're hoping to see that epidemic turnover in a similar fashion to Sydney. And I also just wanted to show what, so those two states have had, both had a reasonable amount of community transmission of SARS-CoV-2 in the last 18 months. There are a number of other states and territories in Australia that have had very long sustained periods without any cases of COVID-19. And so one of them, so this is just a showing for Western Australia, which is currently virus-free, except for some cases in managed hotel quarantine. And they have been like this for a long time. And we can see the population compared to Sydney and Melbourne are very relaxed. And we estimate that the potential for virus spread, if it were present, is very high in this location. And can see that even despite vaccination rollout, even though they're somewhat behind other locations around the country, there's still a long way to go in terms of having a transmission potential that's closer to 1, or which would be in line with the national plan. And I realise my time is up, so I'll stop in a second. That this is just showing that the transmission potential incorporating vaccination is now, as of October, has been included in this common operating picture. And I was going to touch briefly on how these the transmission potential and understanding and incorporating vaccination has impacted, or not impacted, but been useful for understanding how we can produce our forecast of daily case incidence in the presence of vaccination, and that will also be, and for exposure acquired immunity, which will also become something we need to deal with in the coming months. And yeah, I'll stop there. Thank you very much.
Thank you. I don't see any hands up or questions in the chat, so maybe I can just take advantage and ask a question. I think on your last comment, you answered one of my questions I was going to ask about natural immunity and whether that could be worked in, or at the moment, I guess it doesn't need to be just yet. Is that right?
Yeah, so I think we've probably been slow to work in natural immunity, because most of our like before we had transmission of the Delta virus, we would say that our population was 100% largely susceptible, and we would have expected, probably had case ascertainment close to maybe near 100% over the past through 2020, because we partly because we repeatedly eliminated the virus, and so we probably got to most chains of transmission in our population, and so we expect it's probably been a small proportion up until this year, when we've allowed community transmission of since the Delta variant established, and so and we expect now that that's something we will be important to incorporate in these analyses, because it will be driving the epidemic behaviour.
Thank you. And so I think you probably mentioned this, but I didn't quite catch it. So you have this measure of transmission potential,
Mm-hmm.
and does it, when you do have transmission, does it correlate well with RT? Is it, I guess the question is, does it seem to be a good predictor? Reliable?
So sometimes it correlates well with RT and sometimes it doesn't. In the situations where it doesn't correlate with RT, we find that the difference between RT and the transmission potential was sort of in line with our expectations based on what we know from the epidemiology. So if you remember to the pink plots that I showed, that was showing the deviation between those two things. And so when the pink plots were above 1, that would be, say, indicative that the transmission was concentrated in a population with higher levels of population mixing than we would expect from the general population. And then when it hits, so sometimes it's below 1, so we have a negative deviation. And in those situations, it's usually when our public health response is particularly strong, and we find that there's a transmission between people is slower than we might expect in the general population. So sort of indicative of a really strong public health response.
Nice, thanks. And I don't see any hands raised or other questions in the chat. So I think we can just thank Freya again for getting up early in the morning. I guess it's not that early in the morning there, is it?
No, it's not. It wasn't that early.
And we can just transition over to the panel discussion. So I think